I am Peter Tippett, and this is a very great conference. It's really cool to see all the uses of FHIR. Just in the last year, it's exploded, hasn't it? It's come quite along. I started this world as a doctor. I'm an ER doctor. Actually, I'm an internal medicine doctor, but I invented an app that was eventually called Norton Antivirus when I was in medical school. And in order to pay for the startup, I had to do something other than internal medicine. So I did emergency medicine because I could do that at midnight till 8 in the morning, and then work in a software company during the day. So I call myself an ER doc, even though my board certification is in internal medicine. That software and a bunch of other software that we'd all recognize from the early days of the PC, rescue disk and things related to mail merge and undo and that sort of thing, along with some medical record software, and led to a company that was eventually called CyberTrust, which was the biggest computer security services firm in the world. I wound up selling that company to Verizon and became, after a couple steps, Verizon's chief medical officer. A little before there, I had another app or medical product that was trying to solve the problem of EMRs. This was the new world of EMRs, and we took the dictations of doctors and converted them into something that looks structured on the web. I thought we were kind of a small player. We only had 10 million patients with 17 million records and 7,000 recurring doctor users. It turned out we had one of the more active, more populated EMRs on the planet, but we didn't realize we were as big as we were at the time. I was on the PTAC. The first ONC, was born because of the President's Information Technology Advisory Commission or committee. That was Bush's idea of, isn't there some way we can use health IT to solve this cost problem? You can only beat up the insurance companies and the pharmaceuticals so much. And when we got, this was, if you get a chance to work for a president, even if you disagree with the president, it's a good thing. There are thousands of people on these committees are incredibly smart and very, very dedicated. And we had subpoena power, we had the ability, we had a 2-year charge to figure out the question. And I'll summarize a 40-page document in 3 points. We said, if healthcare could only get to, and we've all heard this, could only get to the place where we're using health IT the way banking is using IT, just rough parity, 3 things would happen. 1, everybody'd be wildly healthier and live longer. 2, costs would go down. We projected it'd be around $70 billion a year, but Institute of Medicine came a few years later and said it's more like $700 billion a year. And then 3, we'd have an entirely new kind of science. But other than that, it's probably not worth doing. So obviously, you're all here, as am I, because we bought into the dream that if we could only get people to digitize their use of medicine and communicate it, that and communicate part didn't work out so well, then we could get all those 3 wonderful things. And those 3 wonderful things would wildly change medicine in many, many ways. I would say that we are pretty good in terms of EMR deployment, despite the fact that there's over 500 different EMR, EHR platforms that somebody might have deployed. And despite the fact that if the platform has got a single name, it probably isn't similar in many other organizations. I know Epic people who can't talk to other Epic people. And that shouldn't be that way. But despite all that, we've pretty much got the vast majority of hospitals and the large majority of small practices using some kind of an EHR. What we don't have is them communicating in any meaningful way. And this is where the clinician in me came in. I was involved in the Precision Medicine Initiative when it started with the NIH and the White House as well. And I've got a PhD. I've got them both up there. So the PhD in me is like, let's get some science going. But of course, that means we got to get some parts of medical records to the scientists. So my dream has been for a long time this problem of how do you get medical records moving around? Now, on the PTAC, I signed off on the agreement that led to meaningful use and led to all of the state we are right now. But even in the beginning, I was a naysayer when it came to believing that HIEs were going to actually work. I was on the stage, I remember many times arguing with David Braithwaite and others, Blumenthal, the ONC czars and whatnot, that all pull is not going to work, right? Nothing we ever do on anything in computing is all about fetching records out of structured databases. This just isn't the way everything works. If your boss asks you to give them a document, they don't look in your hard drive and fetch it. They ask you and you send it, right? So we tend to have yin and yang. We have push and pull. We need both for everything to work. So I thought that the sort of push world was missing desperately from the whole first and second stages, especially the first stage of meaningful use, and that led to direct that came up. So here I am a doctor, and as a doctor, I am peeved, I guess I could use worse words, that 10% of the patients I encounter aren't from my facility, they're from somewhere else. If you're in a place like Duke or Cleveland Clinic or Mayo or whatever, it's higher than 10%. These people come here because they're getting their referral work done here, and then they're going to go home, right? My daughter goes to school at High Point, which those of you who are not North Carolinians is an hour west of here. And her doctor is 45 minutes west of here. She gets her heart surgery here, but she can't get her doctor to get any part of the medical record 45 minutes away. And so it goes back and forth with 500 or 600 pages of paper, right? This is really, really stupid. It isn't bad technology. It's not technology at all, right? So the problem we're facing is worse than we sort of imagine. It isn't, so I've had a passion. So I left Verizon a year and a half ago with this passion. I wanted to, this is for those of you clinicians, those of us, we kind of joke about needing our lithium, right? I've got a problem of grandiosity, right? What I'd like to do is solve the world's problem of communicating medical records from anywhere to anywhere. So our tagline is any record, anywhere. So if I give you the punchline right now for this group, it is that we've got a platform at HealthCelerate that allows you to put a FHIR server up in a few hours with your old EMR, without talking to your EMR's vendor, without buying any of their new software, connected to the old services that are already running there. We'll put a plug in front of it, hook up a tunnel, give us a permission, and FHIR is running. So I'll get back to how that works and why we bothered with that in a minute. But it turns out that the ability to, there are about 5,000 hospitals in America, owned by about 1,000 different organizations. There are about 12,000 doctors, clinics, and offices in America, owned by about 10,000 different organizations. So there are about 15,000 entities, or 17, somewhere in there, that have to run FHIR in order to make this stuff that we're talking about work. And right now, the best I can tell, we have somewhere around 1 or 2% of those happening, right? So all the cool stuff that we want to do, and all the cool things that could be done, and all the vitally important things that need to be done are waiting, right? And I'm tired of waiting, right? I just want stuff to work. So we built part of our goal was to build a platform that could solve the problem of a clinician getting a record to another clinician no matter what, whether the CIO is cooperative or not, right? Let's see if we can make it leave one place where there's an EMR, get universally structured, and arrive in another place where there's the EMR, and get inserted into the EMR and be digitally useful. Not at the end as an attachment, but structured so the BUN and glucose and stuff wind up in the BUN table, right? Truly structured. This was obviously a panacea, but that's sort of the goal. And make it happen no matter what, whether it's an old EMR or a new one, whether the CIO has set up services or not, right? So this is what's grandiose about this. Now, what's in the way of this? Well, clearly, clinicians theoretically could, why didn't we share records forever? Well, people could theoretically send stuff back and forth via email. And the problem there was twofold. One, it wasn't compliant. It wasn't safe and secure and HIPAA compliant and all the rest. The other one was that whatever you attached was generally not reusable when it arrived, right? It was an old CDA and it formatted 300 different ways and 12 different types, and God knows how to convert it into what I need in my new EMR, even if it's the same vendor. That often didn't work. So now we have CCDAs, that's better, but we still have a lot of horseplay going on the CCDAs. They often don't have the right link codes or the right kind of structure when they arrive at the new place, and they bounce off, it's unavailable. So we built a sort of a universal CCDA fixer-upper that just inhales whatever the EMR can provide, tears it down to its pieces, rebuilds it back up, and applies the appropriate LOINC or CD10 or whatever code is appropriate on the data arm of that human readable thing, and then makes that available to the next EMR. The next problem with email, of course, was it wouldn't handle files big enough, and you don't really know anything about the rest of it, and it didn't meet HIPAA. So I thought I'd give you a little quick primer on HIPAA. Yeah, I'm simplifying, but in the end, HIPAA requires these four things: end-to-end encryption, which isn't terribly hard; transaction logging, which isn't terribly hard; identity validation, which is nearly impossible for everybody, and everybody just throws their hand up in the air and doesn't bother. Or they say, run it inside the facility, right here in the hospital. So one of the reasons we can't send stuff to the other doctor, I operate mostly in the Northeast, so let's call it New York. And a very large number of people in New York go to Florida for the winter, right? Like my daughter, comes here for her, by the way, my daughter doesn't really come here for her heart surgery. She had her teeth pulled the other day, but just an example, right? My daughter comes here for her heart surgery. Her actual doctor isn't part of the Duke, catchment area, and doesn't have a Duke, account or a faculty position. Therefore, can't log in and get the record. That's very, very, very common, right? So, how would I have a doctor that's, whether they're 45 minutes away or 400 miles away or 4,000 miles away, or maybe they're in India, how would I have my private doctor also get good access to the record? People don't talk about that. One of the major things I did in the last couple of times, that Cybertrust company ran the identity for 25 countries. We ran the national ID card and wound up with 500 million people's worth of strong identity. So we thought we'd try and apply a strong identity system to everybody in America such that they could get their records. And we started with everybody with an NPI entry. So that's a little over 5 million doctors, nurse practitioners, physician assistants, people who can bill Medicare, so pharmacists and whatnot. So that's what's needed for HIPAA. What we did was we started with the direct protocol, and we built ourselves a HISP, and this is 4 or 5 years ago. And we got about 400 total hospitals using this platform, but about 150 are using them for the stuff I'm talking about here. So this allows anybody, to remind you how direct works, direct assigns a strong identity to a person. Could be, normally it's a clinician, like a doctor. And then if you can find that clinician in your directory, you could theoretically send something to that clinician, and it will wind up in an encrypted looking email when it gets there, right? So we built a platform. We deployed it over 100 hospitals that do that. There's a little over 1 million doctors now, or people who have a direct address. And that means they've gone through an identity proofing scheme to prove that they're really the right Dr. John Smith, and they've got the rest of it. What we did in this newer platform is we took that, can I move a mouse? Yeah, we took that system, and this works from any PC to any PC, from any EMR to any other EMR, and we added an app, and this app is just a new addition to the thing. And we said, well, if you're going to send something, it might be a big thing, like a 5-paragraph thing. It might have attachments. The attachment might be an X-ray or a CDA or an output from a SMAC 7 machine or whatever. And if it's in that form, it's probably best if it looks a little bit like an email. So we made an email-looking view for a mobile app, same as the view you'd have if you were on a browser, same thing. We also have the very same message winds up going through that direct protocol, and it can look like text. And we've got some patents around how to speed up things that are mostly fetch-oriented, polling things to make them look like push things. So if you do texting on our platform and send a text, it goes through direct. It winds up at the other address, even if that address is not part of our platform. And it looks to you like text, but it looks to them like email, right? And vice versa. If they send something back, you can look at it in the other format. We can attach a 2 gigabyte attachment to this. We can attach a CDA extract. And if that extract has, and by the way, we can dictate. I was going to do that and show you all the things, but I got my news coming, so I'll skip that. But we can dictate and push the button. And the idea is if somebody's going to send something back and forth to somebody else, it can be automatically imported into the EMR. And how would you do that automated import? Well, direct is supposed to have a connection in the EMR, but that doesn't work as well as it could. And this method works, the direct method works, if you've got a motivated doctor at one end trying to send a message to a motivated person at the other end. And our job would be to transform it into a standard CCDA, make it importable, make it exported, make it pushable, make it all that. But we added FHIR, and the way we did the FHIR thing was, you've seen a screen that looks a lot like this on many of our folks in the last 2 days. I'll just show you a couple of things. So when we hook up FHIR, what we do is hook up our cloud service FHIR, which is running 120 some odd microservices in FHIR. And we generally connect that to a platform that is not running FHIR, and typically that will be XDS. And so in order to do that, we go to a hospital, ask them to set up a 2-way tunnel with us over SSL, so we have to exchange the certificate. We ask them to give us an account, and then we hook up an XDS protocol to that server. If they can deal with any old V3 thing, then they can deal with us. This could be an unupdated EMR from 4 or 5 years ago, and it'll still work. A few hours later, they've got a FHIR service running with the same rights and privileges of all the people in that building. We've done this. We did this at the Connectathon a couple of months ago, a month and a half ago. And Siva, who's sitting right here, I'm pointing to, we brought up 34 connections to back-end EMRs in 4 days with 2 people. So the idea of this is be quick and get a FHIR server running. We're doing a project in Colorado with independent physician groups and IPA, 300 doctors and 100 practices. The average practice is 3 doctors with 100 different EMRs. And we're budgeting 4 hours each to give them a FHIR server. Right? Now, this is only clinical. It's whatever we could get out of whatever it was that could serve us XDS or one of those older protocols. We'll convert it, we pull it in, convert it into a more structured CCDA, and serve up each of the individual elements to whoever it is for whatever purposes. In our purpose, the goal is to get the clinician at the other end to be able to do something with it. But for the purpose of this room, if you want your app to actually work, it'd be nice if the doctors in the community had FHIR running. We're generally able to do that pretty quickly. So that's what we're trying to make happen. It's a little on the grandiose side, but our overall goal is to make it so that anybody can send any record to anyone else. And as soon as we get some of these with FHIR, anybody can fetch any record from anyone else, whether or not they bought FHIR from their vendor. Thanks a lot.